Good afternoon. Before we begin, I would like to let everyone know that this session is being recorded, and these recordings will become available on our DentEcho website after session. We are very happy to have all of you join us for the 31st Dental Education Network for Texas ECHO, commonly known as the DentEcho. This session is brought to you by the UT Health San Antonio School of Dentistry. I'm Kato Kawasaki, and I will assist in facilitating today's session. And Julio will be our wonderful IT support for this session. And if you haven't done so already, please complete the pre-session survey using the link in the chat. And next slide, Julio. And here's a brief look at today's session. We'll start with some housekeeping and introductions, followed by a didactic presentation from Dr. Urankar and case presentation from Dr. Dar. We'll wrap up with a Q&A session at the end, and so please save your questions for then, or feel free to use the chat throughout the session. And next slide. Some housekeeping items for the session today. These sessions are recorded and will be available later on the DentEcho website along with the slides. And please stay muted unless you are speaking. And we encourage you to use the chat or the raise hand feature to share your questions and perspectives. To help us track attendance, please enter your name and organization in the chat. And please remember, no personal health information should be shared in the chat or during discussions. If you run into any connection issues, Julio, our ECHO IT, is available by the chat to assist you. And next slide. Thank you. And for those who may be new to ECHO, this is a model that builds virtual communities of practice and learning. Sessions include a didactic presentation and de-identified case-based learning and group discussion to foster deep knowledge and build individual capacity. ECHO is an all-teach, all-learn supported model, and ECHOs thrive on the interaction from the full learning network. So we encourage everyone to participate in the conversation today. And next slide. And we offer CDE credits. To receive CDE credits, please stay for the entire session. If you want to register for CDE, you can do so now using the link in the chat or by scanning the QR code you see here. When registering, please use the super code ECHO 2026. All right. And next slide. Perfect. Dr. Challa, could you please introduce yourself and please introduce our presenters for today as well?
Thank you, Kito. I'm Suman Challa. I'm the PI on this grant that supports DentEcho. And I'm excited and delighted to welcome and introduce Dr. Yashashree Urankar and Dr. Sohini Dar. Dr. Urankar is a dental public health specialist with over 25 years of experience in both practice, administration, academia, and research. She's been serving as the Chief Dental Officer at a FQHC in Texas for the last 12 plus years and is also an adjunct faculty for both at UT and AT Still. She's also a published author and a reviewer, and she's a nationally recognized leader in integrated whole person care. Her work includes launching an award-recognized emergency room diversion program in Texas. She supported the passage of Texas teledentistry legislation and receiving honors such as Health Equity Hero Award, John Rossetti Center for Excellence Award, and she's also got multiple fellowships, and she's board certified in dental infection prevention and control. She also currently serves as a board of directors, serves on the board of directors of the AAPHD, and locally in Texas on the advisory committee to the Texas Oral Health Coalition, and also on the Texas Association of Community Health Centers, TAC. And Dr. Dar, it's very delightful to introduce Dr. Dar, who's he's an assistant professor in the Department of Comprehensive Dentistry, and also she's been serving as she's a board certified dental public health specialist with over 15 plus years of experience. She's graduated from Sri Ramachandra University in India and for her dental degree and an MPH from the UT Health Science Center in Houston, Texas. And also she's one of our own graduates from our program here in Dental Public Health program in San Antonio. She's got multiple appointments after her graduation in Dental Public Health specialty here in Texas, in NYU, AT Still, and University of Washington. And she's actively involved in multiple federally funded and state-funded grants. Our initiatives address HPV prevention, rural oral health care delivery, workforce development, access to care, and geriatric dentistry. And welcome, Dr. Dar and Dr. Rankar.
Thank you so much, Dr. Challa. Dr. Rankar, whenever you're ready, please.
Let me share my screen. Give me 1 minute. All right, thank you, Dr. Challa, for the wonderful introduction. And our today's topic is, as you can see, it is HPV and oral cancer, from awareness to action. And its association, HPV and its associations with the oral pharyngeal cancers, which are on the rise. We will also look today at the role of the dental professional in preventing it, and also look at how interprofessional learning and collaboration can contribute towards the same goal of preventing this oral cancer. So just an overview of today's presentation. We will talk about HPV, oropharyngeal cancer, the disease burden and the trends, importance of HPV vaccination in prevention and the guidelines for these HPV vaccines, importance of screening, the role of the dental provider, and of course, we'll end with the interprofessional learning and collaboration. So talking about what is a human papillomavirus. The human papillomavirus is the most common sexually transmitted infection worldwide now and in the United States. More than 100 distinct HPV types have been identified, of which approximately 40 infect the mucosal surfaces of the anogenital tract and the oropharynx. These mucosal HPV types are broadly classified into low risk and high risk categories based on their oncogenic potential. The high risk HPV types, particularly the HPV 16 and HPV 18, are capable of integrating into host DNA and disrupting the normal cell cycle regulation, thereby promoting carcinogenesis. So most of the HPV infections are very transient and they are cleared spontaneously by the immune system within 1 to 2 years. However, there is a subset of infections persists, especially when immune clearance is incomplete, and persistent infection with high-risk HPV types can lead to development of precancerous lesions and, over time, invasive cancer. While HPV is widely recognized for its role in cervical cancer, it is also responsible now for causing the oropharyngeal cancers. Looking at transmission of this condition and epidemiology. So oral HPV infection is typically acquired through oral sexual contact, although other mechanisms of transmission are still being studied. The epidemiologic data indicate that oral HPV infection is more common in men than women and increases with age. And these patterns help explain why HPV-associated oropharyngeal cancer disproportionately affects middle-aged and older men. Understanding the HPV biology and transmission is foundational to appreciating its growing role in head and neck oncology and the importance of prevention, intervention, such as use of vaccine. Oropharyngeal cancers represent a substantial and growing cancer burden in the United States. The current estimates indicate that approximately 60 to 70% of oropharyngeal cancers are attributable to HPV infections, making it the most common HPV-associated cancer among men. In contrast, cervical cancer remains the most common HPV-related cancer among women, highlighting important sex-based differences in the disease pattern. According to recent projections, more than 60,000 new cases of oral cavity and oropharyngeal cancers are diagnosed annually in the United States, with over 13,000 deaths each year. Incidence rates are more than twice as high in men compared to women, and the disease disproportionately affects non-Hispanic white males. The average age at diagnosis is in the mid-60s, although HPV positive disease often presents in somewhat younger patients with traditional head and neck cancers. This rising contribution to HPV to the causing oropharyngeal cancer has occurred despite decades-long declines in smoking prevalence. So this divergence underscores the independent and the growing role of HPV as a cancer risk factor. From public health perspective, the burden of disease translates into significant healthcare costs, loss of productivity, and long-term morbidity among survivors, many of whom experience speech, swallowing, and quality of life losses, and these impairments are there even after following treatment. Now, looking at the risk factors for HPV, the primary risk factor for HPV-associated oropharyngeal cancers is persistent oral infection with high-risk HPV types, especially HPV-16. Sexual behaviors that increase the likelihood of oral HPV exposure, such as multiple sexual partners and oral sex, are strongly associated with this infection. Coming to smoking and alcohol impact, smoking and heavy alcohol use can still contribute to cancer risk and worsen the treatment outcomes of HPV positive patients. The importance now of oral cancer screening. Patients with HPV-associated oropharyngeal cancers often present with non-specific or subtle symptoms. Commonly, they present the presentation features include painless neck mass due to cervical lymph node metastasis, persistent sore throat, difficulty swallowing, ear pain, voice changes, etc. Because early stage disease may be asymptomatic, the diagnosis frequently occurs at an advanced stage. So now the role of dental providers in oral cancer screening primarily, and then patient education and counseling. We start with a comprehensive oral examination. The ADA recommends a systematic visual and tactile examination of all intraoral and extraoral tissues at every patient visit, assessing for color, texture, symmetry, and surface characteristics. Now, you have to look for the warning signs as you do this exam. Dentists should look for unexplained pain, abnormal bleeding, any persistent patches or ulcers, tooth mobility, numbness, neck lymphadenopathy, and any mucosal abnormalities that last for more than 14 days. Clinical oral exam remains the foundation for early detection, and any suspicious or persistent lesion should warrant a biopsy and a prompt referral to a specialist to avoid any delays in the diagnosis. Screening techniques, clinical oral exam is by far the largest. Annual screening is recommended for all adults over 18 with increased frequency for high-risk individuals, including smokers and those with HPV exposure. There are some adjunctive detection technologies like tissue fluorescence visualization and light-based systems, increasing detection sensitivity to 94% compared to 74% with conventional exam alone. And the emerging diagnostic tools are salivary biomarkers that show about 89% accuracy for detecting early-stage oral squamous cell carcinoma, with commercial tests expected to receive FDA approval later this year. ADA recently, actually the guidelines on the ADA website are a live document, and ADA has recently recommended cytology adjuncts, vital staining, and light-based screening tools to support clinical decision-making in case of oral cancer screening. Now, the Oral Cancer Foundation, however, has a statement on their website that says, while these tests may find infections through a well-recognized testing protocol, since only 1% of individuals that develop a high-risk type of oral HPV infection ever cascade into cancer, and that most often occurs decades after the infection, that the utility of these tests is highly in question when it comes to providing meaningful and actionable information. The best way still to screen for HPV-related oral and oropharyngeal cancers today is through a visual and a tactile examination by a medical or a dental professional. Now, speaking about the dentist's role in patient education and counseling, patient education and counseling basically should focus on the destigmatization, natural viral clearance, because most of these HPV infections clear out virally, within a few years, and adherence to recommended surveillance about screening, getting an oral cancer screening on a regular basis. Providers should emphasize that HPV is incredibly common, often clears out on its own, and does not have a direct cure, making regular screenings critical to prevent the disease progression. HPV vaccination as prevention. Now, HPV vaccination is a cornerstone of primary prevention for HPV-associated cancers. Currently available vaccines protect against the most oncogenic HPV types, including the HPV-16 and HPV-18, which are responsible for the majority of oropharyngeal cancers. Vaccination is most effective when administered before exposure to the HPV happens, which is why routine vaccination is recommended at ages 11 and 12, or even sometimes as early as 9 years of age. This vaccine has demonstrated excellent safety and efficacy profiles and has already led to dramatic reductions in HPV infection rates, genital warts, and cervical precancers. Although the vaccine was initially promoted for cervical cancer prevention, its benefits extend to preventing HPV-related cancers in both males and females, and the oropharyngeal cancers too. Increasing vaccination uptake, particularly among boys and underserved population, is crucial to reducing the future burden of oropharyngeal cancer. Public health messaging that emphasizes cancer prevention rather than sexual transmission may help improve acceptance of this and coverage. Vaccines can protect against several types of HPVs, including genital warts and some that can cause cancer. The vaccines provide the most protection when people get them before, as I mentioned, before exposure to these viruses. And these above, you can see the ages that the recommended doses are provided by CDC. Now, talking about getting vaccine over age of 26, that those individuals that have not been vaccinated before should talk to their provider about possible risks and benefits of this vaccination. Now, coming to interprofessional collaboration and the dental provider's role. Because adolescents and adults often see dentists or hygienists twice a year, dental clinics could be ideal underutilized settings for catching up on vaccination recommendations. So there are some states that allow dentists to administer the HPV vaccinations, states like Oregon, Indiana, and you can read the rest of them. Broadly, there are about 20 states that allow dentists to administer some form of vaccine. For some states that do not allow dentists to provide the HPV vaccination, some small strategies like simple questions in the EMR on the dentist side where we could ask, did you receive your HPV vaccination for those respective age groups mentioned before? And dentists can make referrals to patients, pediatricians, or primary care physicians to make sure they get those vaccines. And also, on the other hand, our primary care teams will need to learn and proactively participate in performing oral health screenings through interprofessional education and collaboration. They also need to screen not only for the familiar conditions like caries and periodontal disease, but also actively look for lesions and abnormalities in the oral and the oropharyngeal mucosa. Now, with this important aspect of interprofessional collaboration, I will have Dr. Dhar present her case. She is making the case for interprofessional education and practice collaboration to address the rising rates of HPV-associated oropharyngeal cancers through a unique interprofessional initiative that was done at UT San Antonio to promote interprofessional learning and hence a better understanding of HPV and its and the oropharyngeal cancers. So I hand it over now to Dr. Dhar to continue with her part, and we'll come back.
Absolutely. Thank you so much, Dr. Urankar. As we are sharing slides for the case study or the pilot case report that I'll be presenting, I think this point in time in Dr. Urankar's presentation, it's a perfect transition to talk about interprofessional education. Dr. Urankar did highlight the need of interprofessional collaborative work to address HPV vaccination, promote HPV vaccination, advocate for HPV vaccination, and to address and reduce the rate of oral and oropharyngeal cancer. So to expect providers to collaboratively work, to work interprofessionally, it's very important that we give them the education while they are still in school. And hence comes this case study, which I would like to, this pilot case study that I would like to share with all of you regarding interprofessional education intervention that was performed here at UT Health San Antonio between 3 of the schools collaboratively. Next slide, please. We do not function in silos. It's the teamwork that makes the dream work. So before I start with my presentation, I would like to thank my collaborators from the School of Health Professions, Dr. Hill, and from the School of Nursing, Dr. Sisk. It was an equal collaborative effort between the 3 schools, between the 3 faculty, and you will see what I mean by that as I go through the rest of my presentation. Next slide, please. I would not go through each of the competency. You all will have access to this slide, but I wanted to highlight that this intervention, this educational intervention, was based on these 4 IPEC competencies, and you would see how these competencies were addressed and incorporated in the intervention that I'll be talking about in further details. Next slide, please. Learners were identified from 3 different UT Health schools. As I mentioned before, we had faculty from these 3 schools, but the learners are our students. So we had 10 students each from the School of Health Professions, School of Dentistry, and School of Nursing. So the class was, for the pilot intervention was for 30 students representing the 3 schools at UT Health. Next slide, please. Interprofessional education and collaborative activities provide students with the opportunities to know their colleagues in other specialties, to know how to function collaboratively, to know about their responsibilities, to respect each other's responsibilities, and above all, to work collaboratively to give that perfect care, to give that whole body care to their patients. That's our ultimate goal. So the aim of this pilot project was to advance an interprofessional experiential learning opportunity among students from 3 different schools to teach them about how they can work collaboratively to address HPV infection, reduce the rate or screen for oral and oropharyngeal cancer, and promote and advocate HPV vaccination. Next slide, please. The project did focus on peer-to-peer cross-training of related interprofessional skills. So I would like to highlight here the training, the cross-training that happened between the three schools. The students from the three different schools happened 100% by the peer-to-peer training from the students. Yes, the faculty were there to provide that initial training to the students, to provide them with the support and advice as needed, but it was the students who were the main framework for this pilot study, where they taught each other their specialty, expertise, and they worked collaboratively. As I mentioned, we had 30 students who participated. We had physician assistant students teach their colleagues from the other two schools about HPV infection-related didactic content. They also talked about best practice guidelines, and most importantly, they taught their friends and colleagues how to write a perfect SOAP note and how to document. Their IPE peers thought that was a very, very innovative and important part of the education. The nursing students start hands-on training on vaccine administration, and I'll go into details on that part in some of the later slides. And our dental students demonstrated hands-on training on head and neck cancer examination and patient communication on that examination on the screen. Next slide, please. The learning objectives, I'll not go through each of the learning objectives. Of course, you'll have the slides and the presentation to go through them if you would like, and we'll move on to, and these learning objectives are from the physician assistant standpoint. So these were the learning objectives for the educational part that the physician assistant students provided. Next slide, please. So as you can see, this is one of the PA students, a second-year PA students, delivering lecture to a class full of his peers and nursing and dental students on how to write SOAP notes, talking about HPV infection, how it happens, the epidemiology, the transmission, and they were taking the lead in the presentation. Next slide, please. And the PA students also taught how to write SOAP notes. And as we move on to the next slide, we will see in the next slide that there were role play scenarios that the physician assistant students came up with. So they would role play with participation from dental and the nursing students, and they would talk about, okay, this patient came, this is how we communicated with them, this is what we highlighted in the SOAP note, this was the most important part of the SOAP note, and also the conversation. This is how you have an effective conversation with your patient. Next slide, please. These are the learning objectives from our dental students, and we'll move on to the next slide to talk more on how. So this is our DS4 dental students. The DS4 dental students first demonstrated on each other. All four of them that you see here on the slide are our dental students. They demonstrated on each other how to perform a good head and neck exam. And following which they had the nursing and the physician assistant students kind of show them what they learned by practicing on each other. It was wonderful to see them teach and learn and that role play. And then it was so good to see that they were very respectful in talking to their peers if some of the steps were missed. And their peers were very respectful and very receptive to the feedback. Oh, this is not how I do it. This is how I should be retracting the cheek and things like that. It was very good. And as you can see in the first photo, you see a lot of handouts lying on the table. Those handouts were prepared by our dental students and were shared with their peers at the nursing and physician assistant school, where the one I'm pointing on has all the different or lesions that you see or you may see in your patient. And those handouts were color printed and distributed, very helpful for someone who is learning head and neck exam from a dentist or a dental student. Next slide, please. And this is the nursing and the physician assistant students, with one of our dental students overseeing if they are performing the head and neck exam correctly. And it was very, very effective. There was a lot of interactions between the students. And as a faculty, it was a pleasure to watch them learn interactively, work collaboratively, and have that interprofessional education. Next slide, please. These were the learning objectives from the nursing school or the nursing students. We can move on to the next slide. Here, the nursing students taught the dental and physician assistant students, and to me as well, I would say, how to administer IM vaccination. The pink patches that you see are actually practice pads of the muscles that you strap on to your arm. And it is actually like a muscle where you have that hands-on experience of how it would be if you were to provide an IM injection to an individual. The students learned a lot from that, and it was very, very informational. They were talking about the angle in which the syringe should be held, how to load your syringe, and a lot of key points on a perfect vaccination. Our students learned from this process, and honestly, I learned a lot through this process of how the nursing students were showing us how to administer HPV vaccination or vaccination in general in this case. Let's move on to the next slide, please. Here is one of the handouts that was provided by the nursing students, how to fill out the vaccine form, put out the gloves, prep the syringe and supplies, and they have their notes there and administer the vaccine, and then plan the next appointment for 2 doses. It's 6 to 12 months apart, and for 3 doses, it's 1 to 6 months. They had several handouts like our dental students to share with each other, but I thought this was one of the ones that was informative and caught my attention, so I'm sharing just one of them with all of you. Moving on to the next slide. Student practicing IM injection, that's the nursing and the dental students practicing, the PA and the dental students with the nursing student overseeing the IM vaccination on each other. And if you can move on to the next slide. So for any intervention, if you are developing the intervention at our end, we probably are thinking that this is the best intervention ever that I developed. However, we need to know if that's the truth or if that's what the participants or the learners think as well. So we had a very robust evaluation plan for how we would measure the impact of the project. We had pre-post knowledge tests for all the participants. There were validated assessment tools that we used to assess the participants' viewpoints on interprofessional education. There were debriefs in person, and there were written reflections at the end, followed by student surveys. And in the interest of time, I would only share a snapshot of each of these measures with you before we move on to the later part of the presentation. Next slide, please. And here are the snapshots. We can move on to the next slide. And here you see for one of the questions where assessment is the correct answer, this is the pre-survey or the pre-assessment. We'll see that there was an improvement in knowledge, and I can show that to you in the next slide, where we see, moving to the next slide, please, that there was some definite increase in knowledge where more number of participating individuals selected assessment as the correct answer to this question. We can move on to the next slide. There was one knowledge question regarding HPV infection and oropharyngeal cancer, and the correct answer, there was a mix of answers in the pre-assessment, as you can see here. And if we move on to the next slide, we would see that there were more, the proportion of correct answers increased, showing that there were some increase in knowledge, indicating the success of the intervention or the education. Moving on to the next slide. The same pattern was seen for questions regarding intramuscular vaccine administration. We can move on to the next slide. Yes, and you can see there was definitely an improvement in knowledge on the amount of medication that can be provided safely to administer to the deltoid muscle. We can move on to the next slide, and this is the validated IPE assessment tool I was talking about. We used SPICE-R, which is a validated tool consisting of 10 short self-report survey designed to measure health profession students' perception in IPE, what they think of IPE education. And I also have a couple of slides talking about their responses. We can move on to the next slide, please. Next slide. And here we see that most of them strongly agreed that teamwork is important, interprofessional education is important in the pre-test. And if we move on to the next slide, we would see that over there, their agreement increased. They were now more, their beliefs increased. Their beliefs changed to strongly agree from neutral agree to strongly agree after they had the intervention, showing that the intervention, the IPE initiative probably had an effect on what they think about interprofessional education. Moving on to the next slide. Student feedback, perceptions, and future opportunities. Definitely it opened doors for the students to learn how to work intercollaboratively, and for us faculty to expand the project and secure further funding. Student feedback was overall positive. There were many positive feedback, but I'm sharing here my favorite one. Because of scheduling challenges, we had this session on a Saturday morning from 8 to 12. And one of them wrote, it was worth getting up early on a Saturday morning. I intentionally included that here. That tells us that, okay, they spent 4 hours with us on a Saturday morning and they still feel good about it. Was telling us that the intervention or the education was worth it. Some of the accomplishments and future opportunities are, we have done multiple presentations, both at local, state, and national platform, and we want to continue with that initiative. Moving on to the next slide, we'll talk a little bit about what were the overall conclusions. And it was positive learning experience, of course, but the feedback that we got was the didactic lecture. And we take feedback very seriously. And all the collaborators in this effort took feedback very seriously, where the feedback was we could have had the didactic part of the training on a virtual platform and have more time for in-person hands-on experience. Moving on to the next slide. Lessons learned. If we were to redo this study, of course, we had a lot of planning. Faculty met weekly, prepared the students, but we would have more planning. One of the lessons learned was the challenge to schedule the training. All three schools, and for obvious reasons, were on different schedules. That's the reason we had to have the session on a Saturday morning and allow more time to practice the skills, the hands-on training for the students. Now, before we transition to Dr. Urankar to give us the key takeaways and the video, I would like to say the reason behind sharing this pilot case study that was conducted at the school is for all of you, community health partners, providers at community health setting, faculty from the dental school at different stages of your career to think about how we can take this forward. How can we make this intervention a part of the regular curriculum? At a community health standpoint, how can we take similar educational, interprofessional interventions to teach our community health partners, nurse practitioners, dentists at the community health level, how to work collaboratively on promoting HPV vaccination? With that, I would like to again invite Dr. Urankar to give us the key takeaway of our presentation and also share an informational video. Thank you.
All right. So as Dr. Dhar said, and I was listening to her, what was going on in my mind was that the community health clinics, they are in a very unique position to foster this kind of collaboration and collaborative learning. And this would be a perfect scenario for promoting interprofessional collaboration and interprofessional learning, which would definitely work towards getting better outcomes in the community as far as HPV and oral cancer goes. So coming to the key takeaways of today's presentation. The key takeaways are, I cannot press my slide. So as we all know, HPV-associated oropharyngeal cancer is now a major and growing public health concern, particularly in the developed countries. Approximately 70%, as we saw, of oropharyngeal cancers are HPV related, and incidence continues to rise despite declines in the traditional risks such as smoking and alcohol. The disease is biologically distinct from HPV-negative head and neck cancers and generally carries a better prognosis, yet it often presents at advanced stages and causes significant long-term morbidity. Vaccination definitely offers a powerful tool for prevention, but its full impact on cancer incidence will not be realized for several decades. Sustained investment in vaccination programs, public education, and research into early detection is essential to reversing current trends and reducing the future burden of HPV-associated oropharyngeal vaccines. Of course, you cannot underscore the role of the dental professionals and the medical professionals, which is priceless in screening for early detection of these lesions in the mouth. And there are a lot of dentists who miss steps during the oral cancer screening. So I would like to end this video, end this presentation by showing you a video by ADA. It is an old video from 2017, but I don't think the oral cancer screening steps have changed since then. So let's get started with the video. I would like our IT team to help us with that.
Thank you, Dr. Rankard. Thank you, Dr. Dar. As Julio gets the video ready, if you have any questions, please feel free to drop it into the chat. All right.
This video contains the latest recommendations from the 2017 ADA Clinical Practice Guideline on the evaluation of oral mucosal abnormalities. This video offers step-by-step instructions for evaluating adult patients for potentially malignant disorders, or PMDs, and oral cancer during a routine dental exam in your clinic. First, begin the exam by asking your patient if any new dental issues have emerged since their last visit or appointment. During the medical history recollection, pay attention to risk factors such as being male, older, smoking, and alcohol consumption. With the patient's response in mind, next perform a conventional visual and tactile intraoral and extraoral exam. Throughout the exam, use inspection and palpation to look for any changes in color, contour, consistency, and function. Begin the extraoral exam by examining the head and face with both the front and back, taking note of any asymmetries and the presence of pigmented lesions. For such lesions, use the American Cancer Society's ABCDE rule to assess for melanoma risk. Look for asymmetry, border irregularity, color changes, diameter greater than 6 millimeters, and evolution of the lesion over time. Next, observe and palpate the neck on both sides. If lymph nodes are identified, pay attention to the size, consistency, whether they are painful, and whether they freely move or are fixed in place. When evaluating the lips, note any change in the vermilion border, mucosa, and commissures, as well as the lips' color, contour, consistency, and function. Look for indurations and ulceration. Ask your patient to open their mouth and begin the intraoral exam by inspecting the cheeks. Retract the tissue with your thumbs and gently pinch the cheek between your fingers, looking for hidden masses. Use a mirror to examine the alveolar processes and gingiva. Look for changes in color, consistency, or a tooth with bone loss out of proportion with the rest of the arch. Pay special attention to the presence of a lesion with a history of poor healing. Carefully inspect and palpate the hard and soft palate, looking for abnormalities. While depressing the tongue with the mirror, ask the patient to say ah to have better access to the uvula and tonsillar pilars. Using gauze, move the tongue to the left and to the right to examine the entire dorsal tongue. Pay attention to the lateral and ventral tongue as well. Complete this assessment palpating the tongue and nearby salivary glands. This aspect of the exam is important as nearly half of all potentially malignant lesions are usually found in this area. Ask the patient to touch their top front teeth with the tip of their tongue so that the floor of the mouth can be inspected and palpated. Use 2 hands when palpating this area. After the exam, clinicians should consider 2 potential clinical scenarios. Either the patient exhibits no lesions or has some type of mucosal abnormality. For patients without a lesion, no further action is necessary. Although light-based and salivary test adjuncts have been proposed to evaluate mouths without lesions, none of these tools have been proven effective, and as a result, they aren't recommended for use. For patients with a lesion, the majority of these lesions will be innocuous. Some common causes of innocuous lesions include trauma, parafunctional habits, and dental restorations. These innocuous lesions require periodic follow-up with the patient to provide therapy and/or monitor the lesion. In instances in which an innocuous lesion does not resolve, or in instances in which a lesion is suspected to be a PMD, immediate biopsy or referral to a specialist is recommended. Many adjuncts have been proposed as tools to assess PMDs sooner rather than later. Unfortunately, current evidence doesn't support the use of adjuncts because of their high frequency of false positives, which result in unnecessary complications and costs. When evaluating patients for PMDs and oral cancer, please remember, get to know your patient. During your patient's exam, update their history and have a conversation about oral cancer risk factors. Keep in mind that this could be a stressful situation for the patient, and maybe even for the clinician conducting the exam. Time is important. For potentially malignant lesions, biopsy or refer the patient immediately. Be skeptical of the use of adjuncts. Current evidence does not support the use of these tools in the general population. Please monitor and critically appraise the literature for the emergence of new evidence in this field. Look to the ADA's most current recommendations for insights. For more information on the ADA's clinical recommendations for PMD and oral cancer evaluation, please visit ada.org/oralcancer.
All right, we are available for any questions.
Yes, and thank you again, Dr. Dar, Dr. Urankar. That was a very informative presentation on HPV, oral cancer, and also interprofessional collaboration learning. If anyone has any questions, please feel free to unmute and ask. And I see one question actually in the chat. Dr. Patel, would you be able to unmute and ask us? Or if not, I can also read the question as well. Okay, so he asked, which mass screening intervention strategy can be considered to be invested by both financially and training wise at the community level? to bring a substantial change in caseload in precancerous stages?
Okay, that's a good question. But currently, there is no recommendation for any mass screening needed with oral cancer screening for oral cancers, because there is none of the organizations support that, because currently there is no sufficient evidence that it would reduce any overall burden or overall mortality. So this screening, oral cancer screening, you have to seize the opportunity. Whenever you have a patient in the chair, do not miss to do that screening. That would be a strategy that every dentist needs to adopt.
Thank you for that question, Dr. Patel. Anyone else with any thoughts, questions, comments?
Hi,
Yes.
can I ask a question, please?
Yes, go ahead.
So first, thank you so much, Dr. Dar and Dr. Ronkar, for this webinar. As a prospective international dental applicant, I am really interested in this prevention-focused care. So my actual question here is, as someone whose father is a stage 3 oropharyngeal cancer survivor, my father had a left tonsil oral squamous cell carcinoma, and he's on rehabilitation right now. So I have seen this impact that this disease or this is creating the effect on the families. So how can dental professionals better engage not only just patients, but also entire families, which is very difficult, and in conversations around HPV prevention and early detection, when we come from a different background or different cultural perspectives?
I think the answer to this is, again, interprofessional collaboration, and community health centers in the United States, or probably anywhere wherever there's community health programs, the primary care, the behavioral health care, the oral health care professionals generally work together. So the behavioral support, the education can be got from the behavioral health counselors, because it is a problem that affects the entire family. So support for the family is very important. Emotional support. It is a caregiver stress that needs to be addressed at that point in time. And but definitely educating parents and families right from the start, when the kids are young, on the harmful effects of HPV, and getting that vaccination shot before any exposure to HPV happens is important in the area of preventing this condition.
Absolutely. And as Dr. Orankar mentioned, just to add to that and emphasize, caregiver education, caregiver awareness, very important, not only for the topic we are discussing today, but for everything else. Sometimes caregivers are the ones who get neglected, but as you rightly said, Dr. Maheshwari, that yes, it's not just the patient. Of course, the patient is the primary one affected. However, the caregivers are very much affected, and it's not only caregiver care, also that education and awareness among the caregivers, so that they are able to provide the needed care to the patient or the individual affected. Very important. So that's how, and you asked about involving the family right from day one. Very important. That way they can be that effective support system while they're still taking care of themselves, their all over well-being.
Thank you so much for those answers. This is, I think I need to think about the actual caregivers. I didn't thought it before. So thank you so much.
Correct. No, and thank you for sharing your personal story. I'm sure it will, people hearing the story are going to definitely understand better what the impacts of oral and oropharyngeal cancers can have an impact and have on the rest of the family too. Also, one more thing I would like to mention at this point is the HPV is one of the etiologies for oral and oropharyngeal cancers, besides alcohol and smoking, which are now fewer. But if you're talking about culture and coming from different cultures, there are some oral habit practices in Asian countries where there is chewing of the betel nut and smokeless tobacco. These also contribute significantly. So it's not always considered in HPV that causes the oral cancer, oral or oropharyngeal cancer, but these are additional risk factors that could contribute to development of such cancers.
Thank you so much, doctor. So, yeah, you're right. My father's etiology was HPV, and the risk factor was smoking. So, yep, you're right on that point.
All right. Thank you so much.
And I see another question from Dr. Patel. Any quick strategy that dental professionals can use to educate the general population for self-assessment?
For self-assessment, I think the NIDCR has got a lot of informative tools, and there are pamphlets where you can share with the patients, and that teaches them step by step on how to examine their own oral cavity. And if they see any suspicious lesions, especially if they are at high risk, have high risk behaviors and have risk factors that could develop oral or oropharyngeal cancers, it's very important to discuss those strategies with the patient. And while the patient is with you and you are the person responsible for providing that education, you can also train the patient on how they should do self-examination. It's a very important criteria. Thank you for that question.
Thank you so much. Any other questions or comments or thoughts? And I see in the chat a lot of thank yous and comments saying that it was an excellent presentation, which I agree. Any more questions? Yes, thank you. Okay, and right. And please remember the recordings and also the slides will go up on the DentEcho website post-session. And Julio, if you can please share the conclusion slide. Yes, thank you. We have a post-session survey. If you can please complete the survey using the link in the chat, that would be very helpful. And thank you to everyone for joining us for the 31st DentEcho. We hope to see you in August for our next DentEcho. Thank you again to everyone. Thank you, Dr. Dar. Thank you, Dr. Rankar. And thank you, everyone, for being here.
Thank you.
Have a great rest of the day.